Good afternoon. This is Dr. Williams, and I will be lecturing on anemia. So let's get started. I hope by the end of this lecture that we will accomplish these objectives. I want you to be able to identify some of the causes of anemia, be able to explain how anemia is classified and the types of anemia, as well as what the clinical manifestations of each type of anemia, how it is diagnosed, and what are the treatment modalities. If you would like to get more information about anemia and read more about it, in your primary care book, you can go to pages 1278 through 1297. This is chapter 237. This will give you more information that you can read and study related to anemia. Within this lecture, I do not plan on giving you or expecting that you will have the knowledge of a hematologist. However, but you will be able to provide safe, effective, and appropriate care as a primary care provider to any of your patients who present with anemia. So let's get started talking about why anemia is important to primary care. One of the things that is evident is that many patients experience anemia. Anemia can be experienced or has been reported to be a primary diagnosis of about 2.8 million individuals. Research has also shown that within the military women experience higher rates of anemia compared to the civilian sector. There are many contributing factors to that, and not all are known. But what does become important is how do we, as primary care providers, do a better job at identifying what those symptoms of anemia are for our patients and how to treat them so that they can have the best quality of life. So when we're talking about anemia, a point that I really want to make sure everyone understands is that anemia is not a diagnosis. But what it is a reduction in the total number of erythrocytes, which we also refer to as our RBCs, in the circulating blood. Or it can be a reduction in the quality or quantity of hemoglobin and hematocrit. This reduction thus leads to decreased oxygen transport to the tissues, and it can result in a diversity of symptoms. In your book, they classified anemia into 3 categories. I have added a 4th, but I think this helps to kind of organize anemia. The classifications are RBC production disorders. Think about our iron deficiency anemias, chronic kidney disease. The second one is our RBC destruction disorders, sickle cell thalassemias. Then, of course, we have acute or chronic blood loss. That can come from trauma and GI bleeds or even severe menorrhagia. Or the 4th category that I added was a combination of the above. So it's not that you have to have one anemia or another. At times, you may be presented with a patient who actually has symptoms or their labs are reflective of a combination of anemia. So before we start to discuss the specific types or the different types of anemia, it's important for you to understand how we identify anemias based off of how they are labeled. So what I'm talking about here is you're looking at, if you were to identify if a anemia is consistent of a small cell or a large cell, we're thinking things like microcytic or hypochromic. All of this should be a review for you. However, I have enclosed in this slide the terminology to help you understand when we're talking about these anemias and classify them. And so please take a minute to look at these terms, because when you are reading any type of medical record, oftentimes you can identify what type of anemia it is or classify it according to the terminology that is being utilized. So now let's progress to talking about some of the clinical manifestations. What I have done in this lecture is, in the beginning of this lecture, what you're going to see is I'm giving you some characteristics of anemias, no matter what type of anemia it is. Then we will go a little bit deeper and identify what differentiates one anemia from another. So when we're talking about the clinical manifestations, your patients may present with the complaint of weakness, headaches, cold hands and feet, brittle nails, and even the angular cheilitis, which they will get the cracking on the sides of their mouth, chest pain. These are symptoms that can be common across all the anemias. What I wanted to do is also kind of give you a little explanation of what are some of the manifestations that occur with anemia, no matter what type it is. So if you look at this slide and you look at the algorithm, what you see here is that you can have some type of event. You can even have, you can place any one of the anemias at the very top of this algorithm. And what that anemia then does is it leads to what? The decreased red blood cells, the decreased hemoglobin, so the oxygen transport, which then reduces the amount of oxygen that goes to the tissues, and that can lead to ischemia or liver issues. And then you can see how that decrease in oxygen can affect the entire body and thus lead to the diversity of symptoms that patients may present with. So we talked a little bit about some of the classifications of anemia, and we talked about how anemia may manifest in a patient, some of those symptoms you may see. And then we kind of explained why we see those symptoms, that manifestation. Now, what do we do about it for patients who present with anemia? What is the treatment? And that treatment can vary depending on what type of anemia that patient has. And so we're going to go a little bit more into detail as we start to talk about the diversity of anemias. But before we do that, I just want the next few slides will just be a refresher on the red blood cells. What I like to the first component I would like to talk about is the reticular cell count. The reticular cell count is a very helpful test in diagnosing anemia. It is helpful because it allows us to evaluate the bone marrow, where all of the RBCs are actually produced. What this count will tell us is that we can either have decreased production or increased loss. What I want you to remember related to the reticular cell count is that if the count is below 75,000 microliters, then it's considered decreased. That also is the number when we start to think that there is something going on in the bone marrow. So you have some type of suppression, kind of as in like chemotherapy or even aplastic anemia. However, if it is elevated greater than 100,000, then we call that reticulocytosis, right? And that's normally what we get when we see the body trying to respond to maybe having some blood loss. It's trying to overcompensate. So what lab work will we use to assess our patients with anemia? We will begin our lab work. The first lab work that we will do, our initial, will be that CBC. And as you look at the slide, you can see what normal for platelets and your white blood cells should be in a patient who is not anemic. But when we get our CBC, we're not only looking at the actual counts, we also want to look at the morphology. What are the shape of the indices that are reported in that CBC? Let's talk a little bit about what other information you can glean as a practitioner from your CBC results. We all are familiar with the hemoglobin and hematocrit. However, I would like you to think about when you see a CBC report that there are some red cell indices that's on there, which we refer to as like the MCV, MCH, and the MCHC. What these results are, or these indices tell us, is like with the MCV, it tells us what is the actual volume of the red blood cell. This is very important to us as practitioners because it can kind of help us to identify if this patient is experiencing a microcytic anemia, which would be like our iron deficiency anemia, or a macrocytic anemia, which we can see with B12 deficiencies and even some folic acid deficiencies. So we can kind of start to get some differentials of what may possibly be going on with this patient just by looking at this level. We also would then look at the MCH. This will tell us like the mass of the red blood cells, as well as the concentration, which is the MCHC. So just understanding each one of these components as it relates to the blood can help us to be able to provide more information to our patients, as well as a treatment that's appropriate for the anemia the patient may be experiencing. So let's talk a little bit about, well, what is normal? When we're looking at, we talked about the red blood cell indices, such as the MCV, MCH, and MCHC. Let's talk about what is a normal hemoglobin and hematocrit. When do we get concerned or start to think that someone may be experiencing anemia? For females, they say if that level is below 12, and for males is 13. So that's when you start to think there is possibly an anemia going on. Then what we would do is we say, okay, I believe this patient may have anemia. Now let me look at these red blood cell indices to see if it gives me indication or any indication if it is a microcytic, macrocytic, or normocytic. So you can kind of see how looking at that CBC in totality can help improve maybe the treatment or even the options for your patient. So again, here's just a slide to kind of further explain what the MCH and the MCHC, what that means for us as practitioners. So the average amount of hemoglobin per RBC would be our MCH. The average weight of the hemoglobin and a volume of the RBCs, that would be our MCHC. So think about your amount compared to the average weight. That's kind of how you differentiate the two. On this slide, I just wanted to kind of give you some understanding of what is considered normal and what is considered abnormal for you. And it kind of gives you a little algorithm that you can kind of look at to kind of see just by utilizing the MCV if you can want to determine if a patient may be experiencing microcytic anemia, normocytic anemia, or macrocytic anemia. From this slide, you can further see how the terminology utilized to describe anemias and can actually help you classify what type of anemia the patient may be experiencing. Now let's talk about what the RDW tells us related to anemias. This result, which you will see on your CBC report, gives you an indication of the variation in the size of the RBC cells. This becomes important because we know that new cells and old cells have different sizes. So this can help us as a practitioner to be able to see if there may be some type of deficit occurring within the erythropoiesis that is occurring in the bone marrow. It is also known to be a hallmark for iron deficiency anemia as well. On the slide, I wanted to give you an example of what the different red blood cell indices would look like according to the different types of anemias. So we reviewed about the MCVs, the MCHs, and the MCHC. And what I want you to be clear on is, depending on the type of anemia, the results that you see can help you to understand how to classify or categorize that patient's anemia. Okay, so we've covered a lot of background information about anemias. We've talked about how to classify anemias. We've talked about some of the clinical manifestations we may see with anemias and why. We also discussed what are some of the lab results that we may want to analyze to try to determine which type of anemia our patient may be experiencing. So now let's move specifically to talk about some of the most common anemias that you may see in primary care. We will not cover every type of anemia that you may encounter. However, there are several that I would like to give you some clinical information on. These anemias consist of things like post-hemorrhagic, pernicious anemia, folate deficiency anemia, and iron deficiency anemia. So let's talk about these one by one. But before we begin to talk about these anemias, I would like you to kind of put this framework in your mind whenever you're thinking about an anemia. The framework I want you to think about is that you have a patient who presents with either some type of disease or symptom. They present to you clinically. You do a physical exam on that patient. You then get some diagnostics and you start to think of some differentials. And then you begin to understand the need to educate and counsel your patient regarding your findings. So no matter what anemia you may consider, I want you to think about these 6 steps as paramount in each one. Let's start with post-hemorrhagic, which makes sense that post-hemorrhagic would be a normocytic anemia. Usually occurs because of acute blood loss from the vascular space. Usually the major cause for post-hemorrhagic is trauma. And what that patient may present with will depend on the severity of the blood loss. So how do we treat a post-hemorrhagic anemia? IV administration of saline, fluid replacement. And if it's large volume loss, then what we want to do is replace the volume loss with fresh whole blood. Next, let's talk about megablastic anemias. Megablastic anemias is where we have RBCs that are usually large. We thus have defective DNA synthesis, which usually is the result of a vitamin B12 or a folate deficiency. That vitamin B12 deficiency can be also from dietary intake. And then that deficit thus leads to defective erythrocytes. And if we have defective erythrocytes that die, then we don't have enough in circulation, which leads to our anemia. So now I would like to talk about pernicious anemia, one of the most common macrocytic anemias that occur. This macrocytic anemia occurs as a result of B12, a vitamin B12 deficiency. But this deficiency um, is usually the result of an intrinsic factor that hinders the stomach from absorbing vitamin B12. And we know that that vitamin B12 is necessary for red blood cells to mature. So, what causes pernicious anemia? What causes this deficiency in B12 malabsorption? It can be genetics, it can be endocrine disorders, it can be patients who have gastrectomies, any GI issues. Think about individuals also with chronic gastritis, so those GI symptoms. And then even sometimes you have it with individuals who have gastric bypass. As primary care providers, it is important that we recognize some of the predisposing factors that may contribute to a pernicious anemia. So, some of those predisposing factors include endocrine disorders such as diabetes, myasthenia gravis, Hashimoto's. It could be alcoholism, and even ethnicities, those in the Northern European descent, and then sometimes poor dietary intake. So on the previous slide, we talked about some predisposing factors for pernicious anemia. Here, I just want you to see some of the clinical manifestations a patient may present with. I would like to highlight, though, that sometimes in our elderly patients, pernicious anemia can go unrecognized because the symptoms are subtle and slow for progression. So, how do we evaluate a patient that we may believe has pernicious anemia? You can see from this slide that there are multiple diagnostic tests that can be performed. There are some diagnostic tests that you see on this slide that we as primary care providers would not be ordering nor performing. If I have a patient that I feel may have pernicious anemia, I may do the lab work and some of the diagnostics, such as stool for cold blood, even a GI radiograph. However, I would leave the more specialized tests and the more invasive tests for the specialist. This would be a patient that I am now referring to hematology. And in collaboration with hematology, once they have been evaluated, I may co-manage this patient, but this would not be a patient that I would manage myself or perform some of these or order some of these diagnostics alone. And I have included this slide, not that I have performed a Schilling's test, but I included this just for your knowledge, that you would be aware of how they say a Schilling's test should be performed. This is not a test that I've seen primary care order, but it's good knowledge to have. So if you ever have a patient who has pernicious anemia and said they had a Schilling's test, you can kind of understand the philosophy behind the testing. So how do we treat a patient who has pernicious anemia? These patients would go through weekly and monthly injections of high doses of vitamin B12. So what you will see with these patients, they may get 1 milligram injection, sub-Q or IM, of B12. So 1 week, they will get that injection daily for 7 days. The second week, they will get it twice a week. And weeks 3 through 6, they will only get it once weekly, and then they will go to monthly injections. And so what you will see is with these patients, their anemia should resolve within 3 to 4 weeks. However, one thing about pernicious anemia is the importance of these patients receiving treatment. But you can see from the treatment plan that this would definitely be a patient that you would be referring to hematology. I included this slide just to help you with understanding how to assess for pernicious anemia in an algorithm form. So it's all the information we've talked about before, but it just gives it to you in an algorithm. So you can review that and kind of see if you've grasped the concepts of pernicious anemia. Now we're going to move on to folate deficiency anemia. This is also a megaloblastic anemia where you have absorption of the folate, which occurs in the upper small intestines, which is not dependent on any other factors. This is also very common in our alcoholics or those who are malnourished. It has been associated as well with neural tube defects in fetus. So, on this slide, I just wanted to highlight for you all what are some of the clinical manifestations of folate deficiency anemia and the treatment for these patients. These patients are usually treated with folate until their levels become normalized. And then once it is normalized, you normally can stop the folate acid. The other thing with patients who have folate deficiency related to alcoholism is trying to have the conversations and referrals to maybe treatment programs, reduction in alcohol intake, which oftentimes can be a harder conversation and a little more difficult for patients. But however, that also will be part of their treatment plan as well. Let's now talk about our iron deficiency anemia. These are our individuals who have a microcytic hypochromic, so that's small and pale red blood cells. It is the most common anemia that we have worldwide. And you can see here some of the individuals who are in our high risk categories for iron deficiency anemia. And so it's important to know with iron deficiency anemia what the iron cycle is. So I am not going to review this. You can read the slides, and also if you need more in-depth explanation about the iron cycle, you can find it in your pathophysiology book as well. On the slide, I just wanted to give you a visual illustration of the iron cycle. And then this slide just gives you an explanation of iron deficiency anemia pathogenesis, where you have iron loss that exceeds the intake of the progressive depletion of iron. It goes through this cycle where you have a compensatory increase in absorption of your dietary iron and concentration transferrin. The iron storage, however, is unable to meet the needs of the erythroid marrow. And because it's unable to meet that need, plasma transferrin levels increase. And with the increase of the plasma transferrin levels, you get serum iron concentrations that decline. And that decline thus leads to iron not being available for RBC formation. What are some of the predisposing factors for iron deficiency anemia? You can see the list here, very similar to other anemias that we've seen, some of those symptoms, right? Listed on this slide are some of the clinical manifestations a patient with iron deficiency anemia may present to clinic with. Things such as their fatigue, mouth burning, their brittle nails, brittle hair, spoon-shaped nails. On this slide, I like to highlight some of the labs that you may see for patients who have iron deficiency anemia. And I like to just take a minute here to say, if you look back through the slides on the clinical manifestations of anemias, oftentimes the symptoms a patient present with do not help us differentiate the type of anemia. However, our labs become very important with helping us to begin to differentiate. So it's important to know what labs you may need to run and what those results should look like. So how do we treat patients who have iron deficiency anemia? These patients are the patients that we will put on the ferrous sulfate anywhere between 300 to 325 milligrams 3 times a day with meals, or with orange juice. These are the individuals that we see that if they take their iron pills, that we should and can get improvement in their iron levels. But one of the things as primary care to be aware of is individuals who take iron pills can have the side effect of constipation. So it's important that you educate your patient about this possible side effect, as well as give them options and recommendations of things they can do to limit that complication of the iron. There is also a medication called Slow FE, which is an iron that's supposed to be released a little slower, thus allowing the patients not to have as much of an issue with constipation. There is a liquid iron that can be given to children, and I like to tell providers and parents the iron that comes in the liquid form is not palatable at all. So sometimes it can be difficult to get a child to take the liquid iron. So trying to maybe even get the gummy bears or multivitamins with extra iron may end up being a way to treat, depending on what those levels are for your patient. Now, for those patients who cannot tolerate or absorb iron well, then you may need to do the perennial iron, which they have to go and get the infusions for. You can often order those for patients on an outpatient basis where they can go into a facility just for their iron infusions. Normally, if I have a patient that's going to need an iron infusion, that is a patient, again, who will be under the care of a hematologist. And so I will be in collaboration with that patient, but not taking the sole responsibility of that patient and the treatment for their iron deficiency. So what does follow-up look like for these patients? With any patient, not only just iron deficiency anemia, it can vary. These patients should be followed up to make sure that they are getting improvement in their symptoms. Usually, if I am treating a patient for any type of deficient anemia, I will follow up with those patients in 3 to 4 weeks to see how things are going. I will also follow up with patients in that time frame, not only to see if there's improvement in their levels of with their hemoglobin and hematocrit, but to see if they're still being adherent to the treatment plan. It can be difficult to get a patient to continue on iron with some of the possible signs of constipation. That usually is the main reason that patients will stop taking their iron pills. I have added in just an algorithm again for iron deficiency anemia, just for those of you who may need to see it. The process in a algorithm form to help you to be able to remember the process. Now, there is also anemia called thalassemia. Thalassemia is an inherited blood disorder. This is when the body does not produce enough hemoglobin. There are specific types to thalassemia, and it's called alpha and beta. And the type is dependent on the severity of thalassemia. So patients who have thalassemia, they present to you with dizziness, shortness of breath, tachycardia, headaches, leg cramps, difficulty concentrating, and even pale skin. So if you think about these clinical presentations that your patient may have, very similar to some of the other presentations um, of anemia. So how do we treat thalassemia? Thalassemia is treated with blood transfusions. And thalassemia major is when the patients will get regular blood transfusions. When you talk about thalassemia intermedia, blood transfusions are given only if they get an infection or an illness. And then when you talk about thalassemia minor, that is individuals who have been diagnosed with thalassemia, but they do not need blood transfusions. So we have thalassemia major, they're going to get regular blood transfusions once they are diagnosed. Thalassemia intermedia, they will get it only if they get sick or they have an infection. And then you have thalassemia minor, which those have a diagnosis, but they will not receive blood transfusions. Normally with thalassemias, these patients will be prescribed a supplemental vitamin B. They, depending on if it's severe, if they're a major, they may need to have bone marrow transplant. They may even need their spleen or they may even need a splenectomy or cholecystectomy done as a result of that thalassemia. Now let's talk about anemia of chronic disease. It's important to know as practitioners that anemia of chronic disease can be mild to moderate. But what we have with anemia of chronic disease is because of the inflammation that may occur in patients with certain chronic diseases, there is a decrease in erythropoiesis. Some diseases that may contribute to this anemia are diseases that are inflammatory, such as infections, cancers, autoimmune diseases. We often see it also in HIV patients. And because of this chronic disease, we have the bone marrow, which is ineffective in its response to erythropoietin. So with chronic diseases, such as like HIV and cancers that have this inflammatory process occurring, we have this reduction of the ability of iron to bind. And thus, with that decreased ability of iron to bind, we then get a failure of the increased erythropoiesis. And this failure to have this increased erythropoiesis thus leads to a decreased number of erythrocytes. It can also lead to kidney damage eventually, which also affects the erythropoietin. So here is a algorithm just giving you a little bit of the pathophysiology related to anemia of chronic disease. I will not go into details related to this. This is just for your background knowledge. If you want to get more information or you need to understand the process, then please refer back to your pathophysiology book to get that information related to the pathogenesis of the anemia of chronic disease. So, what are the clinical manifestations of patients with anemia for chronic disease? The clinical manifestations are similar to those of individuals who have iron deficiency anemia. Okay, so think about those patients. They may be cold, they may be tired, they may have heart palpitations, they may talk about brittled nails. So, they have those same clinical manifestations. How we evaluate these patients is the same way we evaluate the patient who has the anemia, the iron deficiency anemia, running those same labs. And then what we want to do is see if once we give this patient iron supplements, can we correct the deficiency? If we can, then we can stop the iron once it's been corrected. If not, we have to look at, is it possible to improve the chronic disease? If not, the next step as a primary care would be to consult with hematology to see, is there anything else we can do for this patient? This is a patient who will be seen by a hematologist. These patients may present with hypoxia, pallor, weakness with a fever, and dyspnea that occurs very quickly. And if their platelets are affected, you may see that they may even hemorrhage. How do we evaluate these patients? These patients are evaluated by hematology, and normally it's bone marrow biopsies and blood tests. Treatment for aplastic anemia is usually bone marrow transplant. You can even get peripheral blood stem cell transplantation. They may even try immunosuppression. But one important part of treatment is to identify patients who are at risk. And that becomes important because if we do not identify individuals who are at risk for aplastic anemia, it can lead to death. So let's talk about hemolytic anemia. Hemolytic anemia is when individuals have an accelerated destruction of their red blood cells. It is important to know that hemolytic anemia can either be congenital or acquired. It can also be intravascular or extravascular. And when we talk about hemolytic anemia, what we're talking about is individuals, when you talk about paroxysmal nocturnal hemoglobinuria, you're talking about individuals who have a deficiency in their CD55 and CD59. This deficiency causes a complement-mediated intravascular lysis, and that lysis releases hemoglobin. And this can lead to anemia, hemoglobinuria, severe fatigue, abdominal pain, and thrombosis. Now, when we're talking about autoimmune hemolytic anemias, we're talking about autoantibodies against the antigens that are normally on the surface of the erythrocytes. Okay, so you're talking about one which is paroxysmal nocturnal hemoglobinuria, and then you have the autoimmune hemolytic anemia. On this slide, you can see what are some of the clinical manifestations that may be present in individuals who have hemolytic anemia. It is important to note that patients who present with hemolytic anemia can be asymptomatic. It is also important to note that evaluation for hemolytic anemia includes bone marrow evaluation combined with the clinical manifestations and doing some blood tests. Again, evaluation of any anemia that requires a bone marrow evaluation would be a patient that you would refer to hematology. You can do the labs that are appropriate to be drawn. However, as a primary care, you would not be ordering evaluation via bone marrow. So how are these patients treated? If it is acquired and not an autoimmune, then you want to try to remove whatever the cause or the treatment that led to this disorder. You would then consider giving that patient corticosteroids, and sometimes these patients may need a splenectomy or get to be given a monoclonal antibody. Now let's talk about the G6PD deficiency. This is known as the glucose 6 phosphate dehydrogenase deficiency. It's an inherited disorder caused by a genetic defect in the red blood cells. It generates NADPH and protects RBCs from oxidative injury. It is one of the most common enzymatic disorders of the RBCs. It can lead to hemolysis and even certain infections. I have seen this disorder frequently in African Americans. It is also a disorder we check for frequently in our HIV patients because of the issue with patients who carry this disorder if you prescribe for them any sulfa antibiotics. So what are some of the causes of this deficiency? It can be infections, antibiotics, certain foods, and even certain chemicals. And I always found it interesting that they said mothballs. So how do patients with G6PD anemia present? They can have jaundice, pale skin, dark colored urine, back or belly pain, tired, fatigue, and headaches. If you look at these clinical manifestations, often similar to other anemias. So how do we differentiate? With G6PD, it is, of course, blood work, checking for anemias, but also drawing a G6PD level as well. Treatment for individuals who have G6PD deficiency, they need to avoid foods, medicines, and chemicals that may be triggers. Fava beans are a food that triggers hemolysis in many of these patients, so you want them to avoid those. These patients may end up having the need for a blood transfusion. If it is an infant, then they may need light therapy or individuals who have jaundice. And if they have the long-term anemia, then what you want to do is give them folic acid. Now let's talk about sickle cell disease. It is a common hemolytic anemia. 8% of African Americans carry this gene. It's also seen in other ethnicities as well. The pathophysiology of sickle cell disease, you can see that here. If you need further review of the pathophysiology, please don't forget that you can refer back to your pathophysiology book on sickle cell disease. But the focus here is on what would you need to know as a primary care related to the clinical manifestations, the treatment, and evaluation. So what is the clinical manifestations for individuals who have sickle cell? These patients usually have very severe pain and can also have organ damage. The sickle cell anemia or disease also got its name from the sickling that occurs in the red blood cells. How is sickle cell anemia diagnosed? You can see here they do a hemoglobin electrophoresis and a peripheral blood smear. And when they do their peripheral blood smear, what will be seen is mild to moderate aniocytosis and poikilocytosis. And we'll see numerous sickle cells and how jolly bodies will be present. So how do we treat these patients? Most individuals who have sickle cell, we treat them if they have a mild or moderate crisis. We will normally give them oral analgesics. We need to make sure these patients stay hydrated. They need to get rest, the use of heat and gentle massage. And if they are having moderate to severe pain, then those patients are usually admitted to the hospital or some outpatient facility. They are also given narcotics analgesics for their pain control. And again, they must be hydrated well. These individuals with moderate to severe pain should be monitored every 15 to 30 minutes. And if they are being treated with pain medications and the patients are getting no relief, then their pain medication should be increased by 25% until their pain is controlled. And then there are medications, hydroxyurea, if they have 3 to 4 crises per year. Again, as a primary care provider, we would not be managing their pain if they're in a moderate or severe state unless you work inpatient. However, when you're talking about the mild to moderate, those treatment modalities are things that we may help to start to facilitate. But if you've ever had a patient who had sickle cell disease and had a crisis, then normally those patients are admitted to the hospital, and it's usually for the pain management to try to get it under control. But again, a patient with sickle cell disease, which is different than sickle cell trait, but if the patient has sickle cell disease, they will be followed by hematology and collaboration with you as the primary care. On this slide, I just wanted to give you a little bit more information about what hydroxyurea is. This is not a treatment that we would be administering to the patients, but I thought it was good knowledge for you to have just to be aware of what hydroxyurea is and how it is managed for patients who may be having a sickle cell crisis that is moderate or severe and was not getting good pain control.